Hi, I'm Dr. Rita Gonzalez, and this video is basically about what to monitor in pediatric patients who are undergoing hematologic or oncologic intervention. So, our common procedures are blood transfusion, intravenous and intrathecal chemotherapy, and bone marrow aspirate and biopsy. We occasionally do phlebotomy for patients with polycythemia too. So, one of my objectives is for you to appreciate the value of monitoring your patients while admitted. But this video's objectives are actually for you to be able to anticipate and recognize adverse reactions to common pediatric hematologic or oncologic procedures through proper monitoring. And of course, after recognizing that there is something wrong, to be able to take appropriate actions to the said adverse reaction, even if the action is as simple as turning off the infusion pump, referring to the resident, or calling for help. So we give interventions to improve our patient's condition. However, our interventions will have a potential for complications and adverse reactions. So as good doctors, we have to be one step ahead and anticipate the possible complications of our treatment plan. It is always prudent for doctors to read up on these prior to administering them and prior to monitoring so we know what to watch out for. So for our patients undergoing blood transfusions, I will enumerate the common acute transfusion reactions because these are the ones that you will immediately encounter while monitoring your patients in the wards. So fortunately, the most common reactions are the mild urticarial reactions. These are followed by the moderately severe reactions like moderate to severe urticaria and febrile non-hemolytic reactions. Possible bacterial contaminations are rare. Life-threatening reactions such as acute intravascular hemolysis, bacterial contamination and septic shock, anaphylactic reactions, and transfusion-related lung injuries are not so common. I will leave it up to you to read up on these complications for your better understanding. So when and how often do you monitor? So you do a baseline before starting the transfusion. Upon starting the blood transfusion. During the first hour, you monitor every 15 minutes. For the second hour until the completion of the BT every 30 minutes. And of course on completion of the blood transfusion. After completing it, you monitor again 4 hours after and as clinically necessary. So what do you monitor? Basically, you monitor the vital signs and the general survey. But it's really not as simple as that. You are looking for specific signs. Like for example, when monitoring the patient's appearance, you should be looking for sudden jaundice, icteria, chills and shivering, and reports of pain in the extremities or flanks, because these are signs of acute intravascular hemolysis. Flushing and rashes and respiratory distress may be signs of allergies or anaphylaxis. Respiratory distress is also a sign of TRALI or volume overload, as is puffiness of the face and periorbital area. So you check for the vital signs. Fever can be a sign of febrile non-hemolytic reactions or of bacterial contamination. Check the blood pressure for hypotension, which can be a sign of anaphylaxis, or hypertension, which may be a sign of hemolysis or fluid overload. Check the heart rate. Tachycardia is very, very important. When the body is in distress, the usual first reaction is tachycardia. So an increase in heart rate from the baseline should alert you to a possible problem that you may have to investigate and deal with even before it progresses. Watch out for tachypnea and desaturations, which may be signs of allergies, fluid overload, TRALI, or sepsis. But I tell you, even before tachypnea or desaturations happen, tachycardia will be there already. So, at the end of a blood transfusion, you check for the fluid balance and check the liver edge, which may become palpable with congestion. Blood transfusion monitoring should be recorded on a separate sheet from the routine observation and should be clearly dated and labeled with what components are being transfused. Transfusion reactions should be entertained if there's deterioration in the patient's condition, especially during the first 15 to 20 minutes following the administration of a blood or blood component unit. So, what do you do when you find something abnormal? Stop the infusion of the blood. So, you have to learn how to control the infusion pump. Just turn off the blood infusion and refer to the resident on duty. So next I'm going to enumerate the common acute chemotherapy adverse reactions that you have to watch out for while monitoring our patients in the wards. These include extravasation of the drug into the tissues, vomiting, mild allergies, anaphylaxis, decolored urine, and nephrotoxicity. So when do you monitor? As with blood transfusion, you monitor before starting a new drug. So that's as baseline. As soon as the drug infusion is started, Q 15 minutes for the first hour of each drug. For the second hour until completion, every 30 minutes to 1 hour, or it will depend on the drug. And upon completion of chemotherapy, and then every 4 hours thereafter. Please remember that patients undergoing chemotherapy are immunocompromised, so follow strict asepsis. Wash your hands before entering the room and sanitize with 70% alcohol before touching the patient. Always wear your face mask and do not enter the room if you are assigned to monitor a known septic or contagious patient. And if possible, use the patient's own gear. My patients usually have their own BP apparatus, stethoscope, thermometer, and pulse ox to avoid cross-contamination. Just be sure to leave their stuff in their own rooms. So what do you monitor? Like in monitoring blood transfusion, you are again also basically monitoring vital signs and general appearance. Again, you are looking for specific signs. So in monitoring the general appearance, you check for the sensorium or for confusion, which may occur with ifosfamide or electrolyte imbalance because of excessive vomiting or diuresis. Look for chills and shivering, which may be a herald of an allergic reaction to certain drugs and may eventually develop into flushing, rashes, and respiratory distress. Respiratory distress may also be a sign of fluid overload, which may also happen. Vomiting is a common reaction to chemotherapy, or it may be a sign of anaphylaxis. Again, check for fever, which can be also a chemo reaction. Check for hypotension, which may be a sign of anaphylaxis. Again, look for tachycardia. Also, check for arrhythmias and sudden chest pains, which may occur more commonly with doxorubicin drip. Tachypnea may be a sign of allergies or fluid overload. Watch out for swelling or pain on the IV site or poor IV inflow and backflow. There are some drugs that require more specific monitoring when it comes to input and output and urine characteristics. Cisplatin is a nephrotoxic drug which requires just the right amount of hydration. It is imperative that the patient's I and O be strictly monitored during infusion and on the first 24 hours after cisplatin infusion. We may have to replace excessive fluid output. Ifosfamide and cyclophosphamide also require adequate hydration because they may cause hematuria due to bladder irritation. The character of the urine of patients on these drugs should also be monitored. Look for tea-colored or frankly bloody urine. So what do you do again when there are irregularities? The first thing also is to stop infusion of the drug and refer to the resident on duty. It is important that you guys be able to recognize anaphylaxis because if this is severe, you might just have the time to call the resident for help but no time for you to wait for them to administer first aid. So what is the difference between allergies and anaphylaxis? Simple allergies will usually present as rashes only, whereas anaphylaxis will present with at least one of the following systemic signs: dyspnea, wheezing, hypotension, diarrhea, and vomiting, plus minus rashes and or angioedema. However, you have to bear in mind that vomiting may be a side effect of chemotherapy. So vomiting alone may not be sufficient enough for you to call it anaphylaxis. So we usually have emergency drugs and syringes at bedside so that once recognized and help is called, you may administer these as necessary. So when you recognize that your patient is having anaphylaxis, it is important that you stop the infusion of the medication ASAP. And to be able to give epinephrine at a dose of 0.01 ml per kilogram with a maximum of 0.5 ml intramuscularly. And then you give diphenhydramine, hydrocortisone, and ranitidine as follows. If your patient is hypotensive, you give a bolus of 10 cc per kilogram of plain NSS. And of course, refer. If your patient has rashes only, again, you stop infusion of medication and give diphenhydramine at the same dose. If your patient has vomiting due to the chemotherapy, you give ondansetron every 8 hours. And if still with breakthrough vomiting, give metoclopramide and diphenhydramine. No need to stop the infusion of medication. For patients who underwent intrathecal chemotherapy, aside from those that we have already discussed, you watch out for increased ICP, seizures, and changes in sensorium. Also watch out for respiratory distress because of sedation. If any of these are noted, refer ASAP. Post-BMA patients usually have an unremarkable course. However, you still have to watch out for respiratory distress because usually we sedate them, bleeding at the BMA site, especially if there is very low platelet count. And if with any of the above, please refer as soon as possible. In summary, I have enumerated the common adverse reactions and complications of blood transfusion and chemotherapy. I have taught you how and what to monitor in patients who are undergoing these procedures, as well as the appropriate initial action when such problems are encountered. At your level, it is important that you recognize and know when to refer a patient for intervention. But as future doctors, we also expect that eventually you have differentials and plans of actions for these complications. Most of the time, monitoring seems a mundane task, but it is really essential for early recognition and intervention. Remember that an ounce of prevention is better than a pound of cure. In behalf of my patients, I would like to thank you in advance for your help in their care, and I hope that in turn, they will be able to teach you volumes more than what I can teach you in lectures and in videos such as this. Good luck!